Hi, I'm Dale Sherbeck, and welcome to the HQ, a CHA Learning and Healthcare Can podcast serial where we dive into the healthcare issues and topics from the perspective of its people and discuss them with those that are leading in the health system. Together, we'll try to unpack these topics and learn what actions are being taken to innovatively solve them today. In this episode, we're going to cut to the issue facing healthcare today, what is being called our present day HHR crisis, the crisis of our health human resources, or in more simple terms, the crisis of the people in healthcare. It is a topic on the lips of those in government, including our federal and provincial ministers of health. It is top of mind for most healthcare organizations, and certainly for our health leaders and those that lead people. The headlines are everywhere, in every newspaper and on all our social media channels, including last week in the Hill Times, which read, "There is no health without healthcare workers." It bears reminding that healthcare is a service industry. It's not a production line, it's not a thing we make or that Amazon can deliver. At its core, healthcare is people, people who care, people serving people who need care. People are the heart of what we do. As I speak, our healthcare workers, the people we depend on to care for us, are themselves in need of care. They are burnt out, demoralized, and exhausted. We know many are sick, and without intending to be hyperbolic, we also know some are mentally hurt, so mentally hurt that they have committed or attempted suicide. And many more are leaving in record numbers to the point that the province of Ontario just last week announced it will pay nurses a bonus to stay another 6 months. By all accounts, our current health system stands at the brink of collapse, or at the very least, most agree it is unsustainable into the future. So let's discuss what is happening, and critically, how did we get here? And even more so, how do we build out of this crisis? To explore this topic, I'm very pleased to be joined by Andrée Robichaud, CEO of Central Health in Newfoundland and Labrador. Andrée has acquired extensive experience over the last 2 decades as a healthcare executive and board member in several organizations, and in several provinces and regions at the same time. Andrée also brings strategic planning and policy development experience as the former Associate Deputy Minister for Francophone Services with the Government of New Brunswick. She has also chaired the Conference of Federal Provincial Deputy Ministers Advisory Committee on Health Delivery and Health Human Resources. So I think it is fair to say, if we really want to understand this HHR crisis, there are few better people to talk to than Andrée Robichaud. So hi, Andrée. Welcome to the HQ.
Good morning, Dale. How are you?
Good, thank you. How are you doing?
Good.
So, Andrée, you definitely bring a lot of knowledge and experience on the topic, and I'm certainly struck by the last part of my introduction related to your work with the Advisory Committee on Health Delivery and Health Human Resources. So, I assume that based on that this isn't a new problem, is it?
No, it isn't a new problem. I think, as you stated, I've been in the business for a long time. And when we look at our numbers, I think the World Health Organization estimates that by 2030, we will have a shortfall of 18 million healthcare workers. So being one that's being a CEO that's on the eve of retirement, that concerns me even more because I'm going to be in need of care in the future. I think one of the things in Canada that we're very big at is blaming who's responsible for it. I think that that's not the way we're going to get out of this shortage. I've had the privilege to work at the government level and at the RHA level and at the hospital level in Ontario. And we seem to have a habit of saying, the province says it's the feds' fault, and the RHA seem to blame the provinces. And we seem to kind of, and the unions and the professional associations, we're all kind of looking at each other. And I think that the solution is we need to be working together. So I think that I've been in the business for 36 years. And I remember when I first started, nurses were fighting for full-time jobs. I mean, we had casual pools in nursing that were humongous.
Mhm.
People were looking for jobs. And I think that as we went along, we the more demands we've had on the system. So, from a population health point of view, our demands are increasing. Government have tried to meet those demands by increasing the number of programs. If I look today, the number of programs every jurisdiction have in mental health compared to what they had 20 years ago, you can't compare either. And we've done this to meet the needs, but the supply on our HR, we haven't put a lot of work on that. All right. There's been sporadic work, no question. And I think that everybody, the unions have done a lot of work. The professional associations have done a lot of work. Certain jurisdictions, I look at Health Workforce Ontario, they've done a lot of work. New Brunswick in the early 2000s had commissioned a Fujitsu report that really identified the gaps in and a forecasting model for HR. So, and when I chaired that advisory committee for the Council of Deputy Ministers, there was I would say, a big conversation around an HR observatory for Canada, because if one jurisdiction cannot fix the problem. As we know, we move across our country and our professionals move across. It's got to begin with a provincial initiative and then roll into a national initiative. And the HR Observatory, I think, was a good idea. But after a while, it didn't become about what we did, but it became about the structure and the people and more of the entity than what it wanted to do. When we got into a bit of turf um, issues. So I believe that we've gotten here by not working together, I would say. I think there's everybody recognizes, and today in Central Health, I mean, I am in dire needs of physicians, nurses, especially family practice physicians. And I'm
Mhm.
not the only one in that position. I mean, we've seen Nova Scotia, they've had a huge issue, New Brunswick. These are huge issues.
So over the years, I mean, we've seen perhaps it's uneven, I guess, across the country that, Alberta might be needing more of some particular health profession while there's a surplus in Ontario, or vice versa. Or, I mean, is it different today in terms of what we're facing? Like, is this more unified in terms of our national crisis, I guess, or different than during different eras where it may have been more provincial?
So I would say there's pre and post COVID.
Hmm.
I think we had a problem pre COVID, but the people in the system weren't exhausted. All right. So now you have pre COVID, you had, numerous vacancies and some recruitment issues. And then you took the people that you had that were working really hard and you worked them extremely hard, right? And because we had to, I mean, there was no way of seeing what was going to happen on a pandemic of that size. So, I mean, that had to happen. But when you have a workforce that's already very thin, and you don't have the numbers, it's now we have a workforce that's very tired. I look at my people and I really feel for them. All right. And we're asking them to work overtime. We're asking them to cover shifts. I've had to close some beds in order to ensure that, and we're going into this summer. I want to be able to provide some meaningful vacation for my staff. They've had 2-3 days here, 2-3 days there. But I mean, these people need good, some good time off. So it's a huge issue, right? And people think, well, it's only about bad planning. Well, it's also about the policy uh, um, issues and the decisions that we've made in the past. One of the things that we don't realize, but in some of those rehab positions, some of the credentialing has changed. So we had
Hmm.
degree prepared professions that are now masters prepared, right, in order to be able to practice.
So it takes longer to bring them into the system?
So it takes longer, right? It's when we went from a registered nurse to a Bachelor of Nursing. I'm not saying that that was right or wrong, but what I'm saying is that when you make those policy decisions, it affects your supply.
Mm-hmm.
And those are the things that we need to develop a good forecasting model, is that when you have policy decisions that impact your supply, you need to put them into a forecasting model where you can see what's going to happen in the next 10 years. The other piece around, I think, our industry is that I go back to when I began in the workforce and we had a shortage of IT professionals. All right. And I remember that I was in HR back then when we used to give a bonus to recruit.
Yeah.
What happened is the market adjusted very fast. Within 2 to 3 years, they had produced, the schools had produced those professionals, and that kind of dissipated and went away. It takes 9 to 10 years to train a physician. So
Mm-hmm.
you can't bounce back. It's when you realize that you got vacancies and that you really have a supply issue, you're under the gun in healthcare because it takes so long to develop and train those professionals.
So I'm just, is there a leading indicator, I guess, that would help predict some of those things that we
Well,
should be focusing on, or?
yeah, so I truly believe that you need as a country, we need to put our efforts towards HR planning, and that is developing a forecasting model. And I think the forecasting model is not a big issue. We have a lot of
Mm-hmm.
smart people in Canada, and in New Brunswick in the early 2000s, they had the Fujitsu report where we had, I would say, if you look at it now, it was probably a rudimentary forecasting model, but I mean, we were the only ones at the time. Lynn St. Pierre Ellis actually presented in Washington this model. That's how creative it was at the time. And
Mm-hmm.
I understand New Brunswick updated it once or twice, but then it kind of sat on the shelf. But I think that every jurisdiction, and I think that's a great role for Healthcare Can in terms of bringing the people together, getting an understanding of what our supply and demand is, and then really having a roadmap on what we need. In New Brunswick, I think when we did this, we realized the pharmacist was a big issue, right? So
Mm-hmm.
I think that for the politicians, that really puts it in front of them, right? Because it becomes reality on what's going to happen in the next 10 years. All right. Now, the challenge of a limited budget with a lot of demands, that won't change. But at least I think that if you have a good forecasting model, you can actually say, okay, we only have this amount of money. Let's establish the priorities where we want to increase seats, where we want to do things, right? And it's interesting. One of the things that I think I should mention is in New Brunswick, and I speak to New Brunswick. I've worked in New Brunswick, Ontario, and Newfoundland, so I can only speak to what I know. But when Linda Silas was the president of the union, she introduced the program where nurses could actually come back and work and still receive their pension.
Mm-hmm.
So that affected our supply in a positive way, right?
Yeah.
So policy decisions can affect the supply issue on a positive way and on a negative way. But until we have a mechanism to be able to measure the impact that we will have on those decisions, service delivery model, we introduced nurse practitioners, all right, which again would affect the way your demand and who's treating the demand. So those are all the things that I think that we've had a system has made some great decisions, right? I mean, I've been in the system for 30 years, and it's an industry that's been very difficult because we've had peaks and valleys, right? And
Yeah.
we need to be able to bring that to a level where we make decisions based on good data, and that's not there yet.
So you raised a few things, and I might presume that I understand, but just maybe for some of our listeners who maybe don't, some of what you've described is certainly has been done at a provincial level, and you've been in 3 different provinces. So, why is this a national issue? If healthcare, remains the jurisdiction of our provinces and territories, to do their own forecasting in terms of their modeling for what they need in terms of health human resources, why do this nationally?
A very good. When I look at right now, um, the impact that Nova Scotia is having on Newfoundland on some of my recruitment issues, right? I mean, we are competing against each other. So what we need to be doing is putting in policy. Um, we need to be able to look at a country and say, we're lacking X number of doctors, for instance, right? And if we come up with a number, and I would say primary care doctors are at a premium right now, then the organizations have to react like CARMs, right? We need more resident seats in family practice. So those are some of the things that, if we want to be able to work with our professional associations and our unions, we need to have a bigger picture, all right? Because if someone is increasing their seats enormously, and then the next jurisdiction comes and robs them because they didn't know that they were going to have that issue, it defeats the purpose.
Yeah, I sometimes sort of think about different people holding onto a big sort of balloon, right, and squeezing it, and right, and it sort of just, we see obviously one side of the balloon get bigger, and then other parts sort of, and that, that fundamentally we don't have enough resources potentially in the system, and they just get being moved around within Canada. But I think what's happened, or at least what I hear is happening more during the pandemic, is that there's there's even fewer people, right? So that there's no ability to squeeze that and get enough resources into any one part of the system. Would that be correct?
Yeah, because I look at my region. One of the biggest lifelines we had was locums, right? Well, during the pandemic, the locums weren't coming; they weren't traveling. You couldn't blame them, right? So that put us at a big disadvantage, right? And if we don't do this, I think the other big point is it can't always be about money. All right.
Mm-hmm.
And when a jurisdiction sees one jurisdiction rising their hourly rate or giving them bigger bonus, well, the answer to the next jurisdiction is to give more money, and it just keeps. That's because we don't have the accurate supply, right? So we're
Mm-hmm.
competing with each other. If we put our money in training and developing the correct amount of professionals that we need, and we concentrate our efforts there, we won't be competing with each other, which is what's happening now.
Yeah, it's I find it interesting as you're reflecting on what you're just saying. I don't know if you're a baseball fan, but right with the lockout ended right after, right, all these teams in competition with each other for those people, and they can blame each other for rising salaries, right, because you're trying to track them, but then they're creating this systemic challenge, right, in terms of the affordability of how we fund the system. Um, so I mean, why haven't we fixed this in the past, Andrée? I mean, and I'm cognizant of your point at the beginning about not blaming who hasn't done what, but collectively, why are we here, and why haven't we done something about it if this isn't a new problem?
So I would say, and a lot of people may not agree with me, all right, but I've been in this business 36 years. And when I started in this business, you never heard about engagement. You never heard about patient family centered care. I think that we have evolved and realized that governments can't do it alone. RHAs can't do it alone. Professional associations can't keep do it alone, and neither can the unions. I believe we need to be able to sit around a table and work together to come to a forecasting model that will actually represent our industry. All right. So I've seen numbers like from some of our unions, and I've also heard comments saying, "Oh yeah, but that's the unions; those numbers are inflated." Right? Those are some of the comments that come back and forth. That has to stop. Right? You need to have all the parties sitting around the table and agreeing on how we move this forward. I always go back to Dr. Charles Bolin from the World Health Organization that says it takes five parties to make change. It takes five partners to make change in healthcare. Your policymakers, your health administrators, your education facilities, your community, and your health professionals. If you can bring those five together, all right, then you can make change and you can advance. Now, I've had opportunities in other areas to use that model. We use it for strategic planning where we bring these partners together and come to an agreement, and the implementation goes very well. So I think if we can kind of find a model where we bring people at the table and we get them agreeing on certain principles, we can move to an HR planning model that will support our industry. Because at the end of the day, it's not about supporting anybody else but the patient, right? And when I started this podcast, I said to you, I'm worried about the future because I'm worried about my care. Not as a CEO of an RHA. I'm worried that when I do need care and I get older, which is happening very fast, I find, I'm going to need care, and I need to know that when I walk up the street here to the hospital, that there'll be somebody to care for me, and somebody that's not burnt out. All right, and we know what happens to patient safety when our professionals are very tired. So we really need to do something, and I think that blame it shouldn't be part of our conversation. It's about how do we do it as partners in this industry.
Yeah, so I mean, part of what I'm hearing from you as well is also, I guess, parking some of our individual agendas, right, and coming together with a collective sort of desire or will to work on this. So, I mean, even describing those five parties that you would say that need to be at a table, I would imagine that's easier, maybe not easy, but easier to facilitate at a provincial level. How do you do that, with 13 different jurisdictions?
I think once you've been able to develop a good model, and it's that your model needs to be able to adapt to the different jurisdictions. I think if the provinces are work within their province to develop the forecasting model, but on a national level, everybody's kind of aware of what's happening. Then you take the data and roll it up into one model. I don't think that that's a huge endeavor because every jurisdiction have different policy levers, right? They make different decisions. So Newfoundland might need more nurse practitioners than Ontario. That's not a good example, but an example, right? So when you bring this at a national level, all right, you're going to have a bigger picture on, Canada needs to produce nurse practitioners, and some of the schools, like New Brunswick, we depend on Dal and on Sherbrooke for our physicians. We depend on Quebec and Nova Scotia for our pharmacists. We don't train them, right? So New Brunswick, that's why it needs to go up, because then Quebec and Nova Scotia needs to respond to some of our needs, and we need to be able to demonstrate those needs.
So is there anything else that's missing, I guess, from us being able to do this, Andrée?
Well, I think there are organizations like yours that could take the lead, that you need to bring the governments into the fold. I think that it would be great to see one of our premiers take the lead around advocating for that, or one of our ministers of health, all right? And to there needs someone to step up and say, okay, this needs to be done, all right? I think that advocacy from your organization will definitely kind of help, but we we're an industry that is too important to keep reacting.
Mhm.
We need to get on the other side of reacting, and we need to be planning to be able to be proactive on what's going to happen in the industry. I mean, pandemic is one thing, you can't plan on that, but we were not in good shape before the
I'm going to ask you a question which you may not be able to answer or may not even want to answer. But um, is there something wrong with the way our health system is funded or is conceived, even, that is causing some of these problems?
So our demands are growing. Our population is not. Um, we have a sick population, right? And our demand is growing, and we don't. Um, I believe, and I have a different perspective. I think because I worked in government so for
Mm-hmm.
quite a while, and it was a privilege for me to be able to influence government policy. As a bureaucrat, I think there's so much value. It's so important to be able to provide the government of the day with good evidence-based recommendations. So I think that's number one. Now being in the trenches, all right, um, I see the need a lot closer. And there are a lot of decisions, all right, or recommendations that as a bureaucrat, all right, I would have never made to government had I been in the system, all right?
Yeah. Mm-hmm.
Hence the importance, I believe, for having people going back and forth. And I commend Ontario for that because a lot of their deputy ministers, Bob Bell, and now Catherine's on, are all people from the system, right? They can actually provide advice that they've seen in the trenches. So to me, that is very important. In other jurisdictions, you don't see that very much, and that's very important. But you know, we it's a system that's very expensive, and it's an emotional system, right? It's an emotional service. All right, you're dealing with life and death, and sometimes I believe our system was too focused on professionals and not focused on the patient. All right. So in terms of patient family-centered care, I learned a lot in Ontario. All right. And it is about the patient. And I think that I see Newfoundland has risen and is doing a lot of work on that issue. I mean, I have a patient that sits on my senior team, and she's not very shy to tell me, whoa, you're focused on the wrong thing. It has to be about the patient. So I think that we have a long ways to go in managing the system, but we can't be everything to everybody. And those are hard decisions that will have to be made because I mean, there's not an infinite pot of money here, right?
Mm-hmm.
And how we deliver services. I think that COVID have brought, you and I wouldn't be speaking on the computer today if it wasn't for COVID, right? Providing virtual care. All right. Now, a lot of people are going to say, yeah, well, virtual care is not the best. I think virtual care has a lot of value on follow-ups. There's a lot of ways in regions that are isolated. All right. So there's a lot to be done with virtual care. And I think that, the system, because of necessity again, and of crisis, all right, we've developed these teams. Doctors are providing services. My physician in New Brunswick provides services through telephone, not even through video. And I'm very satisfied with the service. When I need to go see him, I go see him. But otherwise, he does his follow-ups. When I go for blood tests, he calls me, gives me my results, provides me with information on what I should change. It's an excellent service, right? Provides him with more time also to see more patients. So I think there are good things, but I do believe that there are hard decisions to be made in the future. All right. And it's going to be, I think that having a good HR plan will support and help us make those decisions because it's about the resources, right? And over 80% of our spend is on people in healthcare. It's not about gadgets, right? I mean, they're important, but it's about the people.
Yeah, I guess so. What I mean, hearing one is referencing the importance around the patient-centered care aspect. It's around accountability, and the other is, yeah, we do have limited resources, so then it puts more emphasis on the need to plan so that we're using them most effectively, and perhaps even checking ourselves in terms of our values, in terms of how we deploy those resources. Coming back to sort of the aphorism that perfection is the enemy of good, right? So so yeah, I mean, in my own experience, having virtual consults with a physician, it works. It maybe not the best way to develop a relationship. I know that in terms of our running a business in this context, right? It's hard to forge new relationships virtually, but it's easier to maintain relationships you already have in a virtual sort of space. So there has to be a balance in that, I'm sure. But using technology certainly is going to be an important tool in our toolbox. Maybe just sort of as a follow-up question in some of this as well, in terms of our demographics, right? We hear certainly discussions about that, about the baby boomers, right, and the great resignation that's ahead of us in terms of people taking retirement, and the impact the pandemic has had on those choices. What would be your perspective or comments on that?
Well, I'm over retirement age and I'm still working because I want to, right? So although, we can have a very pessimistic view, a lot of people are working beyond 60 now, right? And enjoying themselves. I'm one of them, right? I love the business. I always want to make an impact or um, and I think that a lot of people are tired, and a lot of people have gone through in the bigger jurisdictions where those ICUs were full, and then I look at the Scarborough Health Network, which was I was there for 2 years, and they went through a lot, and they had a good team. I can say that because it was part of my team, but I think we need to be able to give our people a rest, some vacation, some time off, right?
Mm-hmm.
And I think that when you're going through the crisis, you're 60 years old, you say, "Oh my God, this is it. I'm going to retire," right? But when you have a little bit of time and you can kind of take some time off and rest, I think we'll see people come back, and even if it's coming back part time, all right. So I think that that's one thing. The other thing is that when I started in the system, LPNs couldn't give medication. All right, today they can. So I think scopes of practice are going to expand. All right, so out of challenges come innovation and opportunities. All right, so I think that we're going to see the professions change. Like we see our pharmacists now in the last few years do a lot more than they could. Jurisdictions are, they can renew your prescriptions. They can do a lot of things, and some jurisdictions are more advanced than others. All right, so we're going to see, I think, a movement in that way for our professionals to expand their scope of practice. And I think that's a good thing because, if there's one thing that I can say is that we train really great professionals. All right.
Mm-hmm.
We have really good education programs in Canada. So I think that that is a big plus for us. All right. We need to train more and we need to train different. All right. Our bedside people need to be people that want to stay at the bedside, right? and we need to really focus on where our needs are. Again, I'm coming back to our plan, but where are our big gaps, all right? And maybe we need new kinds of professionals, right? We shouldn't be limited by what we have now. Are there other types of professionals that we need, right? And in other countries, they deliver differently, right? I know that, for instance, in rehab, all right, some of the rehab professionals, they can have up to 12 rehab assistants supporting them, all right? They do the care plan, and it's delivered through assistants, right? So there are different ways, and you can train rehab assistants quicker than you can rehab professionals. So I think we need an open mind on how we deliver our services, and we need to input that in our forecasting model and say, if we do this, what happens here, right? That's the tool we're missing. And I think
I was going to ask whether that your discussions about the workforce planning and the forecasting modeling would include a discussion about what professions we need, discussions about scope of practice, and perhaps, I think, as you say, what's missing in terms of those professions, sort of the to fill the gaps. Because I am struck by, I mean, I've heard several people in the last couple of months reference scope of practice and more specifically, inviting us to sort of think about how to get people to work to their full scope of practice or at the top of their scope of practice. Could you sort of explain what that means and how does that help in this crisis and helping us out of it?
So let's use pharmacists. I think pharmacists is a good example. And I can use an example. So in my transition from Newfoundland and New Brunswick, I needed a renewal on my blood pressure medication. All right. Didn't have a physician, right? And the last place you want to go in the middle of a pandemic is into an ER. All right. So I was in a pickle. All right. Had this been 15 years ago, I was in a big pickle. I would have had to go to the ER and wait there. But I called my pharmacist and I said, look, I have a prescription here. Went in, showed her my bottle, showed her my circumstances. She said, I'll extend it for 30 days while you find another avenue, right? Well, 15, 20 years ago, that wouldn't have been possible, all right? So those were pharmacists that are the experts in pharmacology, all right? But we wouldn't let them do that, all right? I think that's a prime example, all right, of releasing these professionals and permitting them to do more within their scope of practice, right?
And the corollary to or consequence of that, right, is that it frees up the time of the family physician or the ER doctor, right, to do things that are at their higher end of their scope of practice, diagnosing or treating and not filling out scripts, right?
Absolutely. 20 years ago, we'd never heard of nurse practitioners in Canada, right? And maybe 30, I'm showing my age here. But you go on the coast of, you go to Cape Cod, and every nurse practitioner, you see shingles, just like a physician's office, you see nurse practitioners' offices, right? So we still have a long ways to go with nurse practitioners, right? And providing them support to working community like our physicians do right now. Again, this will be, a lot of people will support what I said and a lot of people won't like what I said, right? But it can't be territorial anymore, right? It's got to be about how do we service the patient, and all right, and who can service the patient. And our demand is so high right now from a primary care point of view that, we're going to have to look at that and say, okay, who can get out there and provide us with some services?
So maybe just one final question then before we close off, Andrée, and I've really appreciated your insights and assistance in helping to understand the issues here. I mean, I don't see you with any sort of wings or halo or anything like that, no magic wand sort of being able to sort of cast a spell and bring us out of this. So how long is it going to take for us to come out of this? And is there anything, from a short-term perspective that we can do or need to do to facilitate that?
So I wish I did have a halo or a crystal ball that would tell me, look, I've been in this business for 36 years and we've had multiple crises and we always came out of it. So that's the positive side of all this, right? I think that the only thing that's going to get us out of this is for us to stop blaming each other, all right? And come together and say, okay, agree on what needs to be done and do it, all right? And I think the one of the partners that I didn't talk about are the universities, right? The universities, the community colleges, that need to come to the table also. And we really need to look at this together. And you are right, Dale. It has to start at the provincial level, but there needs to be a national link among all of them. So once everybody's done their work, we can actually have a picture of Canada. I mean, CIHI has some good information. CIHI has done a great job, right? Let's not forget CIHI. But they're pockets of information, right? It's about having an integrated way of defining the resources that we need. Because remember, this isn't about making widgets, and it's not about, technology will help us in many ways, but we're dealing with people, and we need people to deliver services. So our efforts have to be about, HR is the most important thing in healthcare. So we need to have a good planning mechanism, and we really need to concentrate on how do we move this forward. A lot of people will say, oh yeah, no. Like we know, just increase the seats and that will be done. That's not how you plan, all right? And there are multiple policy decisions that can be made that will increase our supply. So when we talked about some of that scope of practice, all of those decisions become part of a forecasting model.
Well, I think that's a great place for us to sort of close off the conversation, Andrée. Certainly, I think with certainly instructions or advice in terms of our need for collaboration and coming together, and I think the optimism that we do have people who with the knowledge and the abilities to sort of help us through this. But again, without getting into overused metaphors, but get them all in the same boat, rowing in the same direction, perhaps for a change, and then we can survive this again. And I appreciate you sharing your historical knowledge and, like I said, your wisdom in helping us to better understand this crisis so that we can work together towards that. So thank you very much for sharing your time with us today, and wish you very well. And thanks for continuing to serve your community and us, and not retiring yet. So.
Thank you very much, Dale. It was a pleasure.
Thank you. Take care.
Thank you.
You've been listening to the HQ, and I'm Dale Sherback, your host. You can find this and other future episodes on the CHA Learning website, Apple Podcast, or Spotify. We'd love to hear what you think, so please follow us on our other social media channels. Thanks for joining us in this discussion today. Please join us next time.